Good morning everyone. I am presenting a paper on firecracker related Berlin edema, Diwali's hidden hazard health. Celebration of Diwali comes with bursting of firecrackers, and it also has a hidden health hazard with a potential of serious consequences, in which one of these is Berlin's edema, which is a rare but significant ocular injury resulting from the expulsive force of the firecrackers. In this case series we have patients who presented to the emergency department for 2 consecutive days at the day of the Diwali and 1 day after the Diwali, and the patients underwent comprehensive ophthalmic examination. Visual acuity was taken by finger counting or Snell's chart. Additionally, all patients underwent complete slit lamp examination and fundus examination at the time of presentation and at follow-up visits. Patients diagnosed with Berlin's edema were closely monitored and their visual outcomes were evaluated. The type and mode of firecrackers were also taken into consideration, and the specific types of injury they caused was also taken into the consideration. So we'll start with the cases. The first case is a 30-year-old male who presented to the emergency. The patient had a history of trauma to the right eye from the particle of a bullet bomb. The patient was 10 feet away from the bomb, standing, and at the time of presentation, the uncorrected visual acuity in right eye was hand movement close to face, and left eye was 6/6. In slit lamp examination, AC reaction was present, RAPD was present in right eye, and subconj hemorrhage was present temporarily with gunpowder embedded in it. On the next day, in fundus picture, we can clearly see there is a media is hazy due to vitreous hemorrhage. There was a well-marked Berlin edema, and FR was dull. In the second day, the vision did not improve for the patient. It was hand movement close to face, and left eye was 6/6. In OCT, we can see there is central macular thickness is 212 micrometer, and it also shows perifoveal hyperreflective areas, including the upper layer of retinas. In treatment, the patient was started on oral corticosteroids according to the body weight. Eye drop, Predfort, Nepafinac, Homide, and moxifloxacin and CMC was started. The patient was regularly followed up for 3 months, and the patient's vision improved from hand movement to 6/6 with decrease in AC reaction and vitreous hemorrhage, and no complaint by the patients. In second case, a 9-year-old male patient presented to the emergency with a history of trauma to the right eye with Lakshmi bomb. The patient was burning cracker in his hand, throwing it away when a particle of the bomb hit him. His uncorrected visual acuity in right eye was hand movement close to face, and left eye was 6/6. Slit lamp examination showed AC reaction +3. Hyphema was present, and subconj hemorrhage was also present with gunpowder embedded in it. In day 2, the visual acuity was 3/60. In the fundus photograph, we can see the media is hazy and well-marked Berlin edema is present around the disc. The FR was dull in this patient. In OCT also, we can see perifoveal and around the disc hyperreflective areas, including the upper rail of retina suggestive of Berlin's edema. The patient was also given the same treatment. Oral steroids were started, and same treatment, eye drop, Predfort, Nepafinac, Homide, Moxi, and CMC was started. The patient improved vision from 3/60 to 6/6 with decrease in AC reaction and no complaint by the patient. In case 3, the patient presented 22-year-old male presented to the emergency with a history of trauma to the left eye with dynamite bomb. The patient was standing away from when the particle of the bomb hit his eye. His left eye vision was 3/60 at the time of presentation. AC reaction was present. Subconj hemorrhage was present with gunpowder embedded in it, and laceration was present over the left upper eyelid. The right eye fundus was normal fundus. In left eye, we can see there is a pre-retinal bleed which is shown by the star and green arrow, and Berlin's edema was present, which is shown by the red arrow. In OCT, we can see there is a dome-shaped elevation showing choroidal thickening suggesting of neurosensory detachment in the patient, which is shown by the yellow arrow, and subfoveal deposit of hyperreflective can be present seen below the neurosensory retina in OCT. The patient was also started on the same treatment, and patient vision improved from 3/60 to 6/9 with decrease in AC reaction, resolved pre-retinal bleed, and no visual complaint by the patients. In conclusion, we can see the case series demonstrate that restricting the personal use of firecrackers is a proven method to reduce the number of firecrackers, to reduce the morbidity. But in case of Diwalis, the firecrackers are usually used. So if we are using the firecrackers, the use of proper personal protective devices and community awareness has to be done. The distance and the type of characters also determine the severity of the firecracker's ocular morbidity, OCT is a useful adjunct for monitoring the progress of Berlin's edema. Thank you.
Yeah, you are correctly mentioned OCT is useful, but what are the other hallmark features for Berlin's edema? Clinically, what are the...
So like the first patient presented with RAPD, so it means and he was also having vitreous hemorrhage.
Vitreous hemorrhage, RAPD, maybe due to the other
causes
as
also,
your paper was clearly mentioned is a Berlin's edema. So, but none of your OCT reflecting it. You claim it is in a second day. Second day generally that type of OCT, and it may be PED also in
yes.
one. In
Neurosensitive
OCT it may be
detachment.
PED, pre-existing PED also maybe,
Yes, sir.
and your is macula area that thickness is not as much as. On what basis you are claiming that those are a Berlin's edema?
So firstly, on the basis of fundus examination, we are clearly stating
That's
that
why
it is a
I'm
Berlin's
asking
edema.
first question, what are the hallmark features? Which diopter lens you will prefer to say Berlin's edema?
So fundus examination will show
Yes.
Berlin's edema.
What type of fundus examination?
So indirect ophthalmic edema.
Is it
Dilated indirect ophthalmic.
direct? No, there is no such role of direct nowadays. Is gone. In our time it was there, but in your era there is no such. I think is not available in the market. So I am asking straight question to you: what are the term to examine basically posterior fundus, that posterior pole?
In posterior pole, we can examination depends upon the visibility of the media of the patient.
If the media is visible,
yes, sir.
if media is visible, then
so in slit lamp examination we can do 90.
What kind of slit lamp examination?
Slit lamp examination, 90D examination we can do.
Slit lamp examination one is
with
slit
90D
lamp,
fundus
one
process.
is 90D. Then any other? What are the term of if I examining by a 90D? What is the term? We are examining with a 90 diopter lens along with the slit lamp. What is the term?
90D biomicroscopy.
90D biomicroscopy or slit lamp biomicroscopy?
90D slit lamp microscopy.
Again another question: which lens is best for to detect disc or surrounding area? 78 or 90?
So for for seeing the disc area, 90D is better, and for the periphery we use 20D.
No, I am not asking 20.
90D we will use for. I mean 90D stereopsis is better, and 90D, yes, yes, sir.
Also trying to helping you. That's not asking the question. The reason is that you people are more techno-savvy. That machine may mislead lot. It will be very difficult. Then you moment you can take a good clip. You can send faster than us. But in whatever I am observed now, last 25 years, is we did that high-tech machines. It is our clinical judgments and day to day, day by day is deteriorating. It will be big issues for us in future, because your all OCT, if you send to on WhatsApp or somewhere, we make a is a normal. So should think for your own judgment.
So at the time of presentation, fundus examination was the primary, but at the next day we preferred for.
After few hours. If you claim as Berlin's edema, it should not be like that type of OCT.